Thank you for joining us this morning for what I know will be an informative and thought-provoking conversation on an important topic, behavioral health. The words unprecedented and crisis have been overused in recent years in the context of the pandemic and its impact on all of us. But when we look at what's happening with our mental health and behavioral health systems, it's hard not to call those words into use. We are witnessing a demand for services like we've never seen before. There are pressures and considerations impacting children and adolescents that previous generations didn't face. Social media and the internet among them. And these are contributing to a spike in demand for care for this population. There are numerous studies and reports citing concerning statistics. The CDC reported earlier this year that 57% of teen girls in the US felt persistently sad or hopeless in 2021, and 30% seriously considered attempting suicide. That's up nearly 60% from a decade ago. And on the other end of the spectrum, baby boomers, the most populous generation we've seen until the millennials, will bring a growing need of geriatric services in the future. An estimated 20% of the approximately 100 million people ages 55 and older have a mental health need, which could include anxiety, severe cognitive impairment, or mood disorders. This on the heels of the pandemic that sparked a mental and behavioral health crisis as illness and isolation triggered depression, anxiety, and addiction across all demographics. And we simply do not have a workforce sufficient in numbers to meet the need. According to a report, more than 20% of Ohioans live with a mental health condition or substance use disorder, and nearly 2.4 million Ohioans live in communities that do not have enough behavioral health professionals. Even before the pandemic, a study found that the demand for behavioral health care services in Ohio increased 353% from 2013 to 2019, while the workforce increased only 174% during that same time. Not only is the behavioral health workforce not large enough to meet the demand, it does not match the diversity of the populations it serves. While nearly 1/3 of the US population is Black or Hispanic, only about 10% of practicing psychiatrists come from these communities. A more diverse, representative, and culturally responsive workforce is essential for meeting the need we're facing, particularly as we seek to dismantle systemic racism and achieve health equity. So we're here today to talk about solutions, and coming together in this way is important. As part of our grant-funded opioid work, we completed an assessment to identify gaps in professional education relative to treatment for substance use disorders. One of the key findings of the assessment was the importance of in-person opportunities to connect with and learn from our peers. So coming together today to share stories and experiences and learn from each other is important to our ability to move forward and work together. Thank you to all of our speakers for generously sharing their time and expertise with us this morning. And with that, it's my pleasure to introduce our moderator, who will introduce our panelists. Jeremy Fischbach is founder and chief executive officer of Happy the app. Happy's mission is to create a more supportive culture by expanding access to the essential ingredient of mental health, and by teaching and inspiring people to better emotionally support each other. Prior to founding Happy, Jeremy was the CEO of Mind, which built interactive educational and sports analytics software that leveraged users' psychographic data to improve performance. Jeremy has a psychology degree from Princeton and a JD from NYU. Jeremy, I'll turn it over to you.
All right, thank you, Tracy and Brian, and it's a real honor to be here. I flew from New Orleans yesterday so I could attend and moderate, and we have an amazing panel. So without further ado, I don't know if these are all in order. No, they're okay. So I'm going to start with Dr. Prewitt, St. Vincent Charity Community Health Center. Do you want to Yeah, maybe do a quick intro and then.
Sure. So I'm Dr. Bruner. I work at St. Vincent Community Health Center. I've worked there since October of 2021, and I'm an adult internal psychiatrist. I trained at Ohio State University College of Medicine. I did an adult psychiatry training in Cincinnati, as well as a child and adolescent fellowship training in Cincinnati. And I made my way across the country. I worked 12 years in New Jersey as the medical director for Adolescent Psychiatry unit. I then worked in Virginia for 7 years as the medical director of adult child and adolescent psychiatry unit as well. Made my way back to Cleveland because of family-related issues, and I've been working at St. Vincent for almost 2 years, and I'm grateful to be here. Grateful to be on this panel. I've just the first time I've ever been asked to participate in a panel, so I'm anxious but delighted.
Sorry, let me see if this is get this a little closer.
Okay.
Test it.
But delighted to discuss ways in which we can improve access to care and affordability.
Thank you so much. All right, Jonathan, founder and CEO of Psychiatric Health.
Hi, good morning, everyone. As Jeremy said, my name is Jonathan Lee. I'm the CEO of Signature Health. Signature Health is a community mental health center founded in 1993, and also a federally qualified health center. We have locations in Lakewood, Beechwood, Maple Heights, Painesville, Willoughby, and out in Ashtabula. So we see both urban, suburban, and rural patients throughout the whole lifespan.
Thank you. All right, Dr. Aaron Ellington, Director of Ambulatory Clinical Programming at University Hospitals.
All right, I am still waking up, so help. This is early for me. My name is Aaron Ellington, and I am the Clinical Director of Ambulatory Programming at UH. I've been at UH for 2 years this cycle. Before, I was in there from 2008 to 2014 during my first cycle. I'm a psychologist by trade, and my big thing now that I'm doing there in my leadership position is making sure that all clinical programming is best practice, evidence-based, if it can be, researched, the whole 9 yards, and then also managing counselors and social workers. So my background is, like I said, is in psychology. I've worked for the Summit County ADM board. That's when I left UH. And worked there as an evidence-based practice coordinator. And so got some very macro views of funding and also mental health and substance abuse treatment and programming in Summit County. And so I brought that back to UH.
All right, thank you, Dr. Ellington. Pam Budak, Executive Director of Bluestone Child and Adolescent Psychiatric Hospital.
Thank you. Good morning. I'm Pam Budak, Director of Bluestone Child and Adolescent Psychiatric Hospital, and I'm also the Director of the Woolliger Wellness Center. Both are a part of the Wingspan Care Group located on the border of Shaker Heights and University Heights. Bluestone opened in January of 2022, so we are a pretty new facility. Had a lot of hurdles to overcome in the first year or so, but we are making our way to getting through them and expanding the service model for children and adolescents in our area. A clinical social worker, years of experience working with children and families, and spent a good bit of my career as administrator. So I'm happy to be here today and looking forward to the discussion.
Thank you, Pam. And last but not least, Dr. Julia Bruner, Senior Vice President for Behavioral Health and Correctional Medicine at MetroHealth.
So, can everybody hear me okay? Yes. All right, I recognize the need to lower the mic. So I'm Dr. Julia Bruner. I'm a family medicine doc by training. I've practiced for over 20 years in the field. And over my time frame, I've worked at Metro. So it's where I found my passion. And along that way, I've grown in various leadership roles, and most recently leading our behavioral health program and our correctional medicine programs, and really trying to transform how Metro not only provides behavioral health services, how we proactively engage with our partners across the area to ensure that we are collectively able to touch everyone that needs to be touched.
Thank you so much. All right, well then, without further ado, I think we're going to dive into the questions. So the first question for the panel, we'll start with Dr. Ellington. There are workforce shortages across the healthcare system, we all know that, especially in mental and behavioral health. So the question is, how can we focus our limited resources to address the workforce capacity issues we face while meeting inpatient and outpatient needs?
Okay, I'm going to let you guys know one of the things that we did in our department. So one of the things I initiated in our department, because we were bumping up against basically all of our counselors getting full, and then we turning people away, tons of individuals away, particularly during the pandemic as the need began to rise. So we implemented some short-term therapists. We were going to call them solution-based therapists because no one likes the term short-term, for their therapy. But we've started using, I think, 3 of them, and we're going to add like 3 more to sort of combat this issue. So there's tons of research, by the way. I'm always going to talk about research, about brief therapy and how well it works. But there is a little bit of a stigma that you run into when using brief therapy, because if you tell the client, well, this counselor you're only going to have for a handful of sessions, they go, okay, no, I want the lifetime therapist over there. But if you word it as solution-based, and tell them, okay, when you're coming with an issue or a problem, this person's going to help you, and you don't talk about limiting the time, then we've started to notice a lot of people get referrals from, or our solution-based therapists get referrals. And so it helps, mend a need, that is there in the community, without adding, per se, just tons of clinicians. So, because we were running into not having enough, space, and enough, clinical professionals to actually do the job, and then we needed to, expand on that. So they have a rotating, because they are brief, so they have a rotating caseload in which, as more come off, individuals come off, more go on. And so we're experimenting with that now with the 3 and looking to expand in that. So that's how we're handling that. We're trying to do more groups, so we can manage more individuals, specialized groups, not just, the general therapy groups, so we can get more people served, within our department. So those are some of the things that we've been doing. Recruiting is hard right now because every counselor, psychologist, social worker can get a job anywhere, just throwing a rock, and someone's going to offer them a job. But at the same time, we are also trying to focus on retaining what we have, so we really, with the counselors that we have, we're really trying to focus on, their satisfaction and making sure that they have a good life-work balance.
All right, that's informative. Anyone else want to weigh in on this question? Yeah, John.
Yeah, I would love to. So I totally agree with Dr. Ellington on matching supply and demand. If you look at, the mode, if you look at your data and say, well, what's the mode of the number of sessions that our patients are going to actually show up for and receive, the mode is 1. The vast majority of patients come 1 time, and then they drop out of care, or that's enough care for them. So matching that short-term need has been an important strategy for us as well. And shifting, I think this is fairly common anymore, but shifting to walk-in diagnostic assessments, because we know that scheduling and then having the whole no-show problem is often a very wasteful activity. More and more we're looking at artificial intelligence to predict no-shows. and being able to understand what are the likely folks to come. So that's been important. And then also kind of the longer term game I think that most of us are doing, which is making sure that we're partnering with higher education to help with attracting as many people as possible, and then advocating at the state level for some expansion in some of the credentialing kinds of things. It used to be 20 years ago or so, you could get a social worker license with a degree in sociology or any of the kind of social service degrees, so long as you could pass the social work exam, and that changed, and it's limited the workforce at a time when we need that to move. So it does not make sense to me that those should be independent license. It's certainly kind of an onboarding to the field. And so expanding those opportunities, using technology where we can, and really trying to manage demand, I think is.
Go for it.
So Jonathan and I have had the pleasure of working on a statewide committee with OMAS around this exact issue. And many of the things that Dr. Ellington shared and what Jonathan Lee shared are embedded in that discussion piece. So I took a moment to go back to our notes from those meetings and just write down a few things that I think you would find valuable out of that collective. That collective included people from community-based mental health services, academic programs, private practices, hospital systems, etc. There was a diverse group of people on the panel. And what they came away with was we need to reduce the financial burden in relation to education for those that work in mental health. The amount of time and expense related to tuition for someone who's eventually going to become a licensed independent social worker is far more expensive than it costs to become a nurse. It's just a fact. And that's not to say that nurses aren't valued. We absolutely need and love nurses, but when you start looking at some of the disparities that we've put into play within our system, that's, I think, an important lens for us to have. Certainly, you brought up earlier the value of promoting representation. So our workforce needs to represent the patients that we're serving, needs to be inclusive, and we need to do a better job of recruitment in those areas. And then Jonathan spoke of the concept of really reducing the overall complexity of licensing and ensuring that we can bring people in that have the skill sets, provide them with what they need in relation to training to be able to do that work, and so that we have more people engaged. There are so many kids in school right now that have a passion for mental health. Absolutely have a passion for it. And we need to tap into that now, before they start to, we need to tap into it and we need to support them through that process, because otherwise they'll turn to other careers. It's just a fact of life. They need to earn a living.
Okay. Thank you, Dr. Bruner. There's a lot of questions to get through, but Pam, do you want to jump in?
Yeah, thank you. Just to add to some of the points that were already made this morning, I think the more we can focus and perhaps partner with our educational system, much like there are many young people who are interested in our field, I think we have an opportunity to expose them to our field at a much younger age. Oftentimes we're going to career fairs, which are at the college level. I don't know how much behavioral health represents itself at those same type of career fairs for the younger age groups, middle school, high school. I also think about coursework that is a part of our middle school and high school curricula. They have all sorts of exposure to all different types of sciences and history, and all of those things are important, but there's really not a lot of exposure to anything behavioral health related. And I think if we want to perhaps look at growing our numbers, if we can start to expose our young people a bit earlier to mental health and the nuances that and the different types of treatment modalities, we might spark more interest and hopefully encourage them to pursue our field.
Great. Thank you. Dr. Prewitt.
What I would add to that is our approach as clinicians tends to be a team approach in taking care of patients. One of the things we also have to think about is a team approach in taking care of our colleagues and our staff. So doing this work is exhausting. And when we see a colleague or staff person having a difficult time and needing time off, we need to think about creatively how to incentivize time to fill in those gaps. And it could be PTO time or additional reimbursement to improve retention of workforce. We don't want to lose people when we don't have those gaps. That's what I would like to say about that.
Yeah, I appreciate it. All right, I think we'll move on to question 2. I've seen this a lot with my company. So the transition between inpatient and outpatient care can be a vulnerable time for patients, obviously. How can we improve these processes? And Jonathan, we'll start with you.
Yeah, and I'm sure that Dr. Bruner could add a lot of color to this commentary, which is we have been very intentional in focusing on the transition between inpatient and outpatient, and what we find is a couple of things are really important. Electronic health record interoperability is really quite important, particularly for medication lists, problem lists, so on and so forth. So what we found is when we got onto the Epic platform and were able to have some interoperability with the hospital systems, that was a game changer for us. The second thing, I would call it just intentionality. So placing a social worker physically at the new Metro unit, for example. So there's an idea of warm handoff. The problem is that there's nothing warm about a voicemail box. And so literally to go and have a face with a name that sees the team, the treatment team, as well as in many cases the patient themselves, gives them the comfort, the patient the comfort that they are being kind of well taken care of, and it takes away some of the fear and concern about going to another agency. So I think that I would ask our inpatient colleagues to invite us into their facilities, and I would challenge the rest of the outpatient folks to make sure that you're spending the resources to make that available. I just think of it as really good marketing. But in reality, it's just good partnership.
All right, Dr. Bruner.
Jonathan said it well. I don't need to say anything more.
Okay, Pam.
Yeah, one of the things that we've started doing at Bluestone is very much what Jonathan was just talking about, is attempting to bring in the outpatient providers more to our discussions. I think in behavioral health, we tend to work in silos on the inpatient side and the outpatient side of things. And I think ultimately that impacts the patient experience. So we have been making a greater effort to fold the outpatient providers into our clinical discussions. For those of you who have worked on the inpatient side, you know that those discussions are often rich and full of all of the disciplines that are impacting the inpatient service line. So any opportunity that we have to bring the outpatient provider into those discussions, they often know the patient best, so they will inform those clinical discussions, but it also will help with that transition back to the outpatient setting.
Okay, thank you. Dr. Ellington, Dr. Prewitt?
I'll throw in 2 cents. I'm just going to say levels of care. So right now, it used to be in the past where all levels of care was within one facility. So you went from inpatient, then you went to PHP, partial hospitalization, then you went to IOP, then aftercare, then individual counseling, all within one space. That doesn't exist everywhere nowadays, even within UH. I am trying to bring it back. So I'm talking to a lot of inpatient individuals. I have helped them create a curriculum on the inpatient unit that then, when the client has exposure to that curriculum, then going down to the outpatient, which is what I'm in charge of, and is going to a PHP or an IOP, that curriculum is the same. So for the client, they're going to just stabilizing, maybe hearing a couple of things that they remember, and then getting it reinforced in their outpatient treatment. And so right now I'm working with Rainbow to make sure that we have the whole continuum of care, within UH, which does not exist today. So if I could tell anyone here, if you have, control of that element, try to get your levels of care or partner tightly with individuals within the community to make sure that your levels of care are congruent and consistent.
All right, thank you. Dr. Prewitt, you want to add anything?
The only thing, I agree with the panelists, by the way, the only thing that I would add to that is I'm an outpatient psychiatrist, and oftentimes I have no-shows, and I don't know when a patient's in the hospital unless I do a clinic sync search or an EMR search. And so I really, really appreciate when the inpatient clinicians get a hold of me to tell me that my patient is in the hospital, because oftentimes they don't know. So I'm glad to hear that there's some programming that's being created.
All right, thank you. This is a big one. So the next question is, how can we improve the integration of mental and behavioral health with primary care? Dr. Bruner, you're up.
So MetroHealth has been working within the field of integrated behavioral health for over 20 years. It started off in pediatrics. Dr. Terry Stanson was the lead in that arena very early on. And then we grew it into family medicine just as I was starting to be in attending. So, only 4 years ago. And the purpose of integrated behavioral health, it aligns very well with what Dr. Ellington was just sharing, right? The value of solution-based treatment. And the purpose of it is to ensure that patients have the access early on in relation to managing either a complex situation at home or a complex situation internally to them, or a complex medical situation. And the purpose is to be proactive in relation to that, so that the counseling is instituted early on so that it has an overall positive impact in relation to that individual's outcomes. It's been shown to improve adherence to medical treatment. It's been shown that integrated behavioral health within primary care reduces stigma in relation to receiving mental health services. And it's been shown to provide people with the right skills that or improve their skill development on managing day-to-day life and the things that happen to all of us. And I like to say that it is considered the best kept secret at Metro in relation to getting access to mental health services, right? So whenever I have someone that reaches out to me to say, I need some help. My son is in a situation and he's spiraling. And my first question to anyone when they reach out to me, which is, who's their primary care doc? Because that's where they start. Because they can get in and see that counselor or that psychologist that same day or that next day. Because it's intended, and integrated behavioral health is intended to be available in the moment for patients.
Just a quick follow-up. What are the obstacles to this integration? I mean, who's resisting it, I guess? If anyone.
I think from a process standpoint, you're adding additional team members, right? So you need to be very coordinated in that process, because having a counselor in your building is not the same as having a counselor in your hall. sitting next to you, right? Engaging with you on a regular basis. Because as a primary care doc, I will get busy seeing patients just like everybody else, and I'll get in my mode on my schedule, and unless I see Judy sitting next to me, I'm gonna forget to bring Judy in right away. I may remember it at the end of the day, send her a message, etc. But when she's right there, I know, and the nurses will say, Dr. Bruner, you want to have Judy see Joan? Yeah, that makes sense.
Thank you. Someone else want to weigh in? Jonathan?
I would just add that it is much easier to integrate behavioral health into primary care than primary care into behavioral health. In many ways, behavioral health is still a specialty. And so if you think about specialty, you know, there's not a lot of integration between orthopedics and primary care or cardiac, you know, I mean, primary care is the hub and then there's spokes, and primary care trying to kind of coordinates that. So I think if we remember that behavioral health is often a specialty, that's why it's easier to bring some of that specialty expertise into the primary care setting. That does not mean, though, that those of us who are specialty providers should forget, you know, the head really is attached to the rest of the body. We have to keep that in mind. And so there's real, the process of care is different in behavioral health than it is in primary care. And trying to kind of bend and flex those processes together really takes long, hard, intentional work.
Please.
I'm starting to wake up now. All right, so one of the things that we have done at UH is we have an access clinic. What the access clinic does is that primary care physicians can sort of call in when they need, you know, some help around mental health, particularly around med management. Psychiatrists are in short supply, and then the ones we have are full and, you know, overworked. So we lean on the primary care physicians, you know, to prescribe, but some of them are uncomfortable doing that. So what they can do through the access clinic is they can, you know, basically, you know, have someone who we can get them in within like a week or two, because we're using fellows and everything else to, you know, get the job done. And what they'll do is they'll see these individuals, you know, for 3 or 4, you know, sessions, get them up on the medication, and then transfer them back to the primary care physician with, you know, advice on how to continue to treat the person. So primary care physicians get a little bit more comfortable with the idea of prescribing psychotropic medications. There's way more of them than there are of psychiatrists. And then we, you know, end up, you know, at least on the medication end, you know, getting, you know, clients taken care of. But when they're also in the access clinic getting exposure, you know, to a med manager, we also have social workers working in that department as well. So if they need other services, we can then tie them into other services as well.
Okay, thank you. This is another big one. Dr. Prewitt, we'll start with you. How do we make mental health more accessible to patients when affordability is an issue?
Well, this is a really complicated issue. For as long as I can remember, this has been an issue that the country is wanting to solve. 30 years ago, when I began medical school training during the Clinton administration, there was a valiant but failed effort to solve that problem. And then fast forward to 2008, the Mental Health Parity Addictions Act was passed, and we were all excited. My colleagues and I were all excited about, gosh, this is going to be great. Medical students are going to be encouraged to go into psychiatry. But we all had questions about who's going to have oversight and who's going to ensure compliance. And then in 2010, the Affordable Care Act was passed. And it's controversial, though in my opinion there were some positives to that. For example, pre-existing mental illness had to be covered, no longer could be denied. Patients who were covered under their parents' plans could be covered up to the age of 26 years old. The expansion of Medicaid, so adults who met the federal quality poverty guideline of 130% could be approved for Medicaid at that time. So that was wonderful. A survey from OMAS back in 2015 determined that post-Affordable Care Act, the percentage of adults covered for Medicaid increased from 9.5% to 18.7%. Wonderful, though there were some challenges with the Affordable Care Act. For example, we still have had issues with transparency and parity. As someone mentioned earlier, getting psychiatrists paneled has been a long, arduous, complicated situation. Can you imagine the solo practitioner seeing patients and getting paneled at the same time? Can't do it. So it's estimated at this point that 45% of psychiatrists don't accept primary insurance. And it's even worse for Medicaid and Medicare. So it's estimated that 35% in solo practice accept Medicaid versus 73% of primary care physicians. Now, there are lots of complicated reasons as to why that happens with respect to billing and coding and CMS valuing the complexity of primary care visits over behavioral health visits, which they say is a cognitive assessment. So I don't know exactly what the answers are, though I can share with you what I and the St. Vincent community do in an approach to solve this problem with accessibility and affordability. So when a patient presents to us without insurance, we point them in a direction or get them assistance with presumptive Medicaid, and that will cover them for a year. And hopefully in that process, they'll get covered by one of the 5 managed care Medicaid companies in Ohio. Hopefully within that year, they'll get paneled with with one of the 5 Medicaid managed care companies. And as you all know, there are issues around transparency of reimbursement rates with all those Medicaid companies, so that makes it even more difficult for psychiatrists to maintain Medicaid. So, as you can expect, I see patients in the office who come to me and say, gosh, doc, life is my stressor. And that tells me that their mental health treatment is secondary to the basic necessities of life. So an example that illustrates that, I have a patient that I've been seeing in the office who is in their 2nd trimester of pregnancy, has a history of psychosis, has a history of psychiatric hospitalizations, and she has unfortunately has had a number of no-shows. Of course, I wanted to see her at least 1 to 2 times a month because of all of those issues. So in one of the appointments that she managed to come and see me, she says to me, oh, doc, not only have I not been going to your appointments, I've not been going to my OB appointments at Metro. And she's in her 2nd trimester of pregnancy, and she has not been taking her medications consistently because she's not been able to get transportation to the pharmacy. She also tells me that she doesn't have consistent access to a phone so that she can get her reminders of when her appointments are. And the most heartbreaking of all, she tells me, I haven't eaten all day and I'm hungry. Can you give me some food? So St. Vincent is uniquely located in downtown Cleveland area that provides services to a primarily indigent care population. So fortunately, I was able to do a number of things for her. So I was able to connect her to our Crisis and Recovery Support Service. They are grant funded. They were able to provide her rides to not only me, but also her OBGYN appointments at Metro. We have access to grant funding that covers lifts back and forth to my appointments. In addition, she was also able to get nutritional assistance. So in my mind, it's really the basic necessity of life that get in the way of affordability and access to care. The last thing I want to mention is, you probably have heard the release. 2 weeks ago, the Ohio Department of Mental Health and Addiction Services approved a capital grant fund for a collaboration between the ADAMS Board, which is the Alcohol, Drug, Addiction, Mental Health Services Board, MetroHealth, and St. Vincent to create a crisis center. This crisis center will provide wraparound services, psychiatric emergency room services, and a crisis stabilization unit, which is planned to open in the fall of 2024. The crisis stabilization unit will have 16 beds and will help those individuals who need more time in the hospital for linkage to outpatient community care or for hospital placement. So there are things, of course, that we can do with Congress in terms of, and I don't know the answers to how to go about this, to get Congress to improve transparency, regulations on parity, but in the patient population that I treat, grant funding, capital grant funding is really, really what helps us to provide those services to our patients.
Thank you. That was, yeah, that's an amazing story. Anyone else want to weigh in? Okay, I know we have a lot more to get through. Telemedicine technology. So does technology, specifically telemedicine, enable us to address workforce capacities and improve access to care for populations in need? Are there any additional considerations we need to be aware of? For example, quality of care when providing mental and behavioral health services virtually. Dr. Bruner.
Yeah, so first of all, I'd like to thank Dr. Prewitt for all that she shared. That was amazing. Thank you.
Congratulations.
Thank you. So telemedicine, there are a variety of different ways we can look at this. Whenever I talk about telemedicine at home, my mom says, "Girl, we were doing this in Alaska 30 years ago, and so now this is a thing here." And so the point of me bringing that up is there is a telemedicine in general has been this thing that we went to because we had to, because it was an access issue. Certainly in rural settings, in remote settings, telemedicine has been the lifeblood in relation to ensuring people had access to services. And now we're transitioning into this concept of telemedicine being something that we should curate, that shouldn't be the second hand process that we use for those that don't have access otherwise. We're rather looking at it a way that we can expand it and really enhance how we provide care. Telemedicine, as I was sharing with my family's history around my mom living in Alaska above the Arctic Circle for 20 plus years, was something that allowed her to have access to services along with the Native population that she was working in. It also provides, when we think about the quintuple aim in relation to healthcare, it provides not only improvement in just general population health capacity, helps us with our costs of care, certainly helps with patient experience, but it also, if we do it right, and I'm being very intentional around the doing it right, we do it right, it reduces healthcare disparities. And it certainly, if we do it right, reduces provider burnout. So I think for telemedicine in the future, as we build it out, we need to be very intentional around how we do it, because we could just slap it together like we did during COVID, right? Or we could actually make it into something that really does improve the overall health and well-being of our population.
Do you have any examples of doing it right versus not?
I do.
Oh, yeah.
Good morning.
Good morning.
Thank you for putting this together, but I can't hold my peace. Y'all are talking at us, and I know there's a lot of expertise sitting out here, so I want to let us share the floor. But in terms of telehealth, I am a therapist. I do all of my clients online, and it can be done right. It does reduce no-shows. I have very few no-shows because they don't have to worry if they have gas. They don't have to worry about if the bus is running on time. They don't have to worry about if they need childcare because they can listen at least in the other room versus moving a kid to a whole nother location to get to another location for themselves and then to repeat that backwards. So it does work. It's been working. You're absolutely right. We have to get on board with that, and we have to be a part of the solution so much faster. We will committee meet things to death. Let's talk about the meeting for the meeting and schedule the next meeting. We have technology, we have expertise, we have talent. Let's just do it. So in the spirit of being solution driven, let's actually put the rubber to the road. And so I'm Dr. LaShawn Sawyer. Sorry to interrupt the panel, but I have expertise too, so I just, when you said telehealth, that's my lane, and I just wanted to share.
And we'll have a quick Q&A too, so yeah, I appreciate it. Dr. Prewitt, do you want to jump in?
So I really thank you for that. The thing that I would add is that I understand that CMS is covering telehealth coverage through the end of 2024. So we're going to be able to utilize
Yeah,
that.
that's a challenge, right? I think we need to continue to show the value and what it can bring.
Anyone else want to weigh in on this one? Jonathan, Dr. Ellington, Pam? Okay. Next question. So as the overall population is aging, a growing segment of patients in need are ages 55 and up. Conditions such as dementia, Alzheimer's are important considerations. I'm seeing these with my parents. How are we growing capacity to meet the needs of older patients? Jonathan?
Yeah, I don't know that I'm the foremost expert in this area, but it is an area that Signature is focusing on more and more. There are far fewer geriatric psychiatrists than there are even child and adolescent psychiatrists, and so the expertise is few and far between. At Signature, we were fortunate enough to hire a board-certified geriatric psychiatrist, and one of the initial asks immediately was, can you please put together a training series, a didactic series to help inform many of the rest of the medical staff, particularly our nurse practitioners, physicians as well, but the psychiatric folks as opposed to primary care, so that we can impact a whole lot more patients. There's also a need, frankly, to focus on this population in the curricula for social work, counseling, so on and so forth. It's interesting. There are lots of people in the field here in the audience. If I asked you all to name the child adolescent agencies here in town, my guess is given a few minutes, you could name off 10 or 12 of them real quickly. And if I said geriatric, you might be able to name one. So it is a huge capacity issue, and baby boomers are driving that demand. They've been driving the demand for mental health services their whole lives, and so now here it is on this end of the age spectrum. It is, and also CMS has finally recognized this. So they're now including LPCCs in the benefit starting the first of the year. Community mental health centers will now be able to bill Medicare for intensive outpatient, which is really important for our seniors that have opioid use disorders. Oh, by the way, the IOP benefit also covers other mental health issues besides substance use disorder. So there's really this is kind of like telemedicine. It became real popular when it was starting to get paid for. Same thing I think will happen here in the geriatric spaces. Now that there are more clinicians that are able to access Medicare benefits and new levels of care that are able to be paid for, we'll start to see some focus, but it kind of circles back to the workforce issue, because now you still have a skyrocketing demand and not enough people in the field.
Anyone else want to weigh in on that one? Okay. Next question. So exasperated by COVID and other environmental factors, social media is contributing to the growing demand for child and adolescent mental health services. How are we addressing the need for adolescent care in order to slow down or reverse this epidemic? I've seen this a lot in my work. Pam?
Sure. So I think the short answer is we're not doing enough. I think there's a lot more that we could do to help our young people manage social media appropriately and really have it be a positive influence in their life. We all know that social media is not all bad, that there are definitely some benefits, especially when we look at what its intended original purpose was to expand social networks. And I think when our young people have the opportunity to do that in a positive way, they actually can expand their support network, and those networks can help them get through the difficult times. But on the contrary, there's a lot of negativity, things like online bullying, different things that come up with social media use. And I think our first step should really be to look at stigma. And I think the stigma around mental health impacts our young people's experience with social media. For those who maybe are the victims of, some bullying behaviors, I think stigma influences their inability or reluctance to reach out for help, to a trusted adult, whether that's at home or school. I think stigma also influences those who are on the other end. Those are the ones who are maybe doing the more targeting types of behaviors. And when they, are aware of individuals who are maybe experiencing some mental health symptoms or in mental health treatment, I think their views and their impression from stigma influences the choices that they make. So I think addressing stigma will help our young people. I also want to emphasize the role of parents. I think as a parent myself, I often think that my son's peer group is, the number one influencer of his life. And when I can take a step back from that and recognize that still myself and my husband as his parents, we are still an important and probably the most important influencer for him. So I think when parents can, be empowered to set limits, that will help their young person. So, setting healthy boundaries around social media use is important. But I think when parents also take a look at their own use and really reflect on how much time are they spending on social media, and is the topic at the dinner table, how many likes somebody got or what post somebody put up, I think that really just sets the tone for young people about how important social media is or isn't. So I would encourage parents to continue to pursue their own interests, having that real life engagement rather than spending time on devices or cell phones. I think that will set the stage and model for our young people appropriate use.
Okay, thank you, Pam. Before our Q&A, we have one more question. Substance use is sometimes discussed separately from mental health needs. The two intersect in ways we're just beginning to truly understand. What is being done to understand and address these connected needs? Dr. Ellington?
Okay, now I'm going to get on the soapbox because I hate when these two topics are separated. I do understand the history behind why they are separated, but I need us to move past the history. It is all behavioral health. And so when we start separating substance use and addiction from mental health and think of them as different, we have a problem already. They are the same. It's all behavioral health. There are behavioral components of addiction. There are behavioral components of mental health. And we need to put them together. So I have departments, in our department that you would think they're like different islands. We have ARS, which is our addiction recovery services, and then we have like IOPs that are behavioral health. And one of the things I am going to do by God, is we are going to have dual programming within our department. It makes no sense for us to have this antiquated way of looking at things, in 2023. Tons of research, is out there about comorbidity. Okay, both need to be addressed at the same time, in the same way, while at the same time having the clinician be well versed in both. So in other words, you don't go to school for mental health and that's it. You don't go to school for, addiction and that's it. You go for both. In my past life, I used to teach right down the street at Cleveland State University, their master's program. And I brought up this annoyance, to the professors there, Ingersoll, to be more precise. And I said, why don't we have this within the, the master's program? They need to be learning about, chemical dependency at the time and, they not just mental health. And he said, fine, you teach it. And I was like, all right, I will. So I wrote the curriculum for it, and to this day, they now, have a whole slew of classes that, are in mental health. Why did I even care? Because I know I only had one class out of my entire PhD program in addiction. One class. Okay, that's ridiculous. This is behavioral health. So I should have been learning a lot more about, addiction than that one class, as if it was a side note. And so I would, encourage everyone to, have more dual programming, have more educated clinicians on both sides of the spectrum. So when they have someone in front of them, who is smoking a lot of marijuana but doesn't really want to talk about that, they just want to talk about their depression, they recognize that, that may be a component that I need to look out for. I will hop off my soapbox.
Thank you, Dr. Ellington. Hey, Jonathan, do you want to jump in?
I'm on the same soapbox.
Yeah.
Which is, it is absolutely preposterous to think that you'd go see a family physician and that family physician would say, I don't really treat high blood pressure. It's laughable, but yeah, it happens in our field all the time. We hire clinicians that say, I don't really, I don't prefer those patients, which is fine if you don't prefer those patients, but that we need you to be well versed in it because that's our specialty area. So I don't know that I have a whole lot to add other than in some cases I think it's malpractice to ignore one side of the fence or the other. If you're a chemical dependency counselor like me, there's a scope of practice issue, but but it's on me to then refer someone who has the appropriate licensure to be able to handle dual diagnosis, because the vast majority of our patients are struggling with dual diagnosis.
Okay, thank you. I think we have some time for Q&A, right? Okay. Anyone want to ask the panel a question? Please.
Would you mind coming up here? Would you like me to bring the microphone?
Hi, this is really fascinating and very thought-provoking. My name is Ed Nevercheck. I work for the YMCA. I run a program called Whitehaven, serves people who are homeless. And so I was just, one of the challenges, one thing I heard from Jonathan, how hard it is to integrate outpatient into inpatient. And so what are some things that you have done or others have done to kind of bring medical services into behavioral services?
The two that I think we've already mentioned have been the most effective in my view, which is, I'll call it co-location, send somebody physically there from outpatient into inpatient. And then the telemedicine option has also been something that's been really quite helpful. But the basis of both of those is making a human connection with that patient and the kind of the other partner, if you're starting outpatient and I want to partner you with a residential care or an inpatient or vice versa. Let's face it, anyone is more likely to show up if there's going to be a friendly face. And so making that connection, I find, is really, I can give you a name, I can give you a phone number, I can even get on the phone and call and schedule an appointment, but the likelihood of you going is so much greater when you face-to-face tell another person, I'll be there.
Well said. Who else has a question for the panel?
Hi, I'm Tom Homestead. I'm
Oh.
St. Vincent Cherry. I don't think I need to get up there, but
Yeah.
so thank you for all your comments. Very, very much thought-provoking. So a couple things. One is, Dr. Ellington, I think you mentioned that it's differentiating mental health and substance use disorder is part of the problem. On that screen right there, it says the mental and behavioral health crisis. I've always been confused about the terms that are used, and if I'm confused, and I'm somewhat in this space, then people who need care or people who provide care may be confused as well. So behavioral health, in my view, is the umbrella term for mental health and substance use disorder. But right there, we use behavior. So what is behavioral health relative to mental health in the way that that's presented? So I think the terminology that we use is inconsistent. And I think that leads to confusion on so many different levels. The other thing is, so that's just my little pet thing. But it seems to me that it's so easy to change the paradigm of physicians that, as you said, Jonathan, it's almost malpractice when they don't take the time to screen for a behavioral health issue. ESPERT is a common tool that's used, but in our experience, it's always been a function of grant funding. And as you've all spoken to the issue, some directly and some not so directly, about the funding that's required for all of the work that you do or all that we do, it would seem to me that ESPERT should be a common tool. If you're a physician, and a primary care physician, like Dr. Bruner, family care, you're going to, by God, you're going to look for everything you can possibly find in that patient that may be a cause for illness. Why not have your practice be incorporate ESPERT into for every single patient? Every single patient. When we talk about the statistics of mental health in this country, shouldn't the process be where you also look at, without question, what the mental health issues may be or what the substance use issues may be? We lost people that were responsible for ESPERT because the grant funding went away. That just seems so crazy to me, and it's not that expensive. So the tool is there, the funding is fragmented. So I think if you start at the bottom and look at really very basic, simple tools to start this process, that makes sense to me. So I'm curious to what your thoughts are on that. So thank you.
Okay, I'll start. I'm trying to bring behavioral health to be the umbrella. I'm bringing it back, because I do think that there is a language issue. And I think the divide that has been there for quite some time is a part of that, language issue. So to talk about it, and I know that there's individuals who would go push it even further and say, why are we just saying behavioral health? Why isn't it just health? And I get that argument as well, because then we're dividing ourselves up, making it ourselves a specialty, and no longer do MDs or DOs have to think about that particular part. So, there's that crusade, but I can only wage one war. And so I'm more in the umbrella war of, this is all behavioral health. As far as measurements are concerned, it's funny, when I came on board, I did actually put measurements in place that every, client will take, but not the not the BARTs though. It's the DAS and the MAS. There's one that's combined that looks at both alcohol and drug. They're free measurements, by the way, that anyone can use to determine drug and alcohol abuse. So everyone does receive that, at least in our department, because you're absolutely right. It sort of takes, it's a screener, by the way, folks. It's not a determination for diagnostic assessments. But at the same time, it will flag an individual, who may need a little bit more or something different, than just, run-of-the-mill, type of treatment. It may be something more that needs to be added. So I'm in agreement with it.
Can I add to that response?
Please,
Yeah. Okay. So, Tom, you're spot on, right? We've been having this conversation around universal screening within MetroHealth, and how can we implement that? And one of the so we are moving forward with that in relation to primary care. The caveat to that is ensuring that, like with any screening, you got to make sure that you have the folks that can manage it once someone screens positive. The primary care docs don't want to be left in the lurch, right, from their perspective in relation to ensuring that that patient has access to services. Because there's always that fear, right? I find something and now I'm going to clean my language, now I have to deal with it, right? And for primary care and overburdened practices, that's an honest challenge that we have to work through. It doesn't mean that we shouldn't do it. It means that we have to figure out how to do it. But what I will say is at the jail, everybody that walks in the door gets a full mental health screen, gets an audit, and a DAST in relation to looking for alcohol use disorder and other substance use disorders. Everybody that walks in the door. And that's about 21,000 visits a year.
For those that aren't familiar, SBIRT, the acronym is Screening, Brief Intervention, and Referral to Treatment. If I said to you, what disease space would that cover? You could easily say it could be, as a primary care physician, I'm screening for cancer, or when I refer out, or I'm screening for an orthopedic issue and screening out. In the case of SBIRT, it was developed for three things. One, to screen for substance uses or mental health disease, and then trauma. So it's just anyway, I've already said that. So
And it's Medicaid reimbursable.
I'll just say one other thing on the terminology, which may have been wasn't addressed quite as much, but my company we do proactive, peer-based mental health support. We work with active duty military, doctors, nurses, veterans, Medicaid plans, and what we find is that behavioral health, mental health, that's all pretty stigmatizing to the people we're serving. We talk a lot about just a whole different type of terminology for the people who we're supporting, talking about having someone in your corner. I mean, more often than not, we find the people who we support want to hear is not mental health, behavioral health, or anything like that. They just want simple terms like somebody who's there for you. So just throwing that out too. So I think we have room for one more question. Please.
I'm Jody Mitchell. I'm with Aetna Ohio Rise. It's great to sponsor this morning's breakfast panel.
Thank you.
And discussion. And I wanted to talk about Ohio Rise is a new plan for youth 0 to 21 behavioral health. So not only do we cover their behavioral health services, but we also provide a care coordinator and care manager that works with the youth and family according to their voice and choice. I think that's important that we work with and for the youth, not telling them what they need necessarily, but listening to them. And that care manager has been really helpful in meeting the SDOH, social determinants of health needs. And I know Dr. Prewitt talked about that one case where that member came in with multiple other issues that really contribute to the outcomes related to mental health. So I wanted to ask the panel about the role of care coordination and social determinants of health and how, like, our care managers pull all the different providers together that are servicing that youth into a care family team to help coordinate and work together and build upon the treatment plus the SDOH. So how does that reflect in your work and what you're seeing in your population?
Who wants to take this one?
I'll start. At Bluestone, we have done a lot of coordination with the Ohio Rise CMEs, and we actually are one of the CME providers for Lorain and Medina County. So we've started that linkage and connection. It's still something that we will continue to pursue and make sure that we are looping not only the care coordinators in, but making sure that the family is aware of the service as well. And really the idea is, the primary idea is to address the social determinants of health. And a lot of our time with our social workers as they're discharge planning, they're looking at all the resources needed by the family. It's oftentimes not just the mental health treatment, but we work to make sure that they have the ability to get to the appointments. So transportation is a big piece. We try to use school-based providers a lot also because that's very easy for the child to receive the services if it's provided in their school. Although it has some drawbacks, I think it's difficult to process a trauma and then go off to gym class. So I think there are some things that really are limiting with that service model, and also doesn't keep the parents engaged, but it's definitely an opportunity for that youth to receive services. So I think coordination of care is always something we should be striving to improve.
Thank you so much. I know we're out of time, so I'll just say before Brian comes, thank you so much for an amazing discussion and just for the amazing work that all of you do, and for everyone here for taking some time to talk about this issue. So yeah, really enlightening.
Good morning, everyone. I'm Brian Lane and President and CEO here at the Center, and I have the privilege of bringing this morning to a close by extending gratitude on behalf of my team here. Thank you, Jeremy, for leading this incredible conversation, and to each one of our panelists for taking the time to be here this morning and share their thoughts and expertise on this very, very important topic, and actually I'd say topics. Pam, Jonathan, Dr. Bruner, Dr. Ellington, Dr. Prewitt, thank you. All right. I also just want to say thank you to all of you for being the leaders within our community and taking care of us as well as our patients here. And that is not in my notes, but that's from my heart and from my spirit, and I just want to say thank you. Okay? Yeah, I cleared up with that a little bit. So, and thank you for joining us this morning within the room and for this engaging conversation. You help make these events extremely enriching, not only for us, but we take the information back and we change our processes. We make adaptations to the way that we're actually caring for one another. Does that make sense? Yeah. Okay. So please, participate, get involved with us, but at the same token, take the time to actually meet one another. That's how we make this thing happen, okay? I want to thank our event sponsors. And typically folks always do that at the front. I'm going to do it at the rear end of this. Ursuline College, Aetna Better Health, and Ohio Rise. Thank you, thank you, thank you. Champs Group Purchasing, bless you. Our sponsors are such an important source of support for events like this, and you can learn more about our sponsors within the booklet. If you haven't already, I encourage you to take a look through the program. There's some great information in there, including the link to a documentary that Carrie Lang and team put together. It's called Igniting Compassion, which was created to address stigma. It includes personal stories from patients, their families, their clinicians about SUD treatment and recovery here within Cleveland. Okay? If you haven't seen it, go to YouTube, look at Igniting Compassion, and take a moment. I guarantee you it will bring you to tears. And with that, we've come to a close, and I want to thank you all again, and have a great, great day.